So it's an opportunity if colleagues aren't here able to join us today, they can view the recording in their own time. So great to have you here. It's the governors' meeting is always really important for us because it really brings together the voices of our members and our communities, which is the whole kind of the reason for governors, which is incredibly valuable for our organisation, and really just great to. I think looking forward to a good agenda. This is the first one that I've done, and those of you who haven't met me, I'm Faisal Hussain. I'm the interim group chair for NHFT and LPT, and great to be here with you. We've got some apologies to be noted. We've got Heber Lisa Pearson, staff governor, Heber Kadir, staff governor, and Anu, also a staff governor. And we've got apologies from NHFT Chief Executive Angela Hillary, Chief People Officer Sarah Willis, and Non-Executive Director Duncan Orme, who've sent their apologies. Are there any other apologies that need to be noted before we move on?
Yeah, we've got a few more from Adam Webb, who's Public Governor. We've got RuPaul Shah, Public Governor, and we've also got Sharon Wormersley, the Partner Governor, and Laura Kaus, Public Partner Governor as well.
Okay, right, great. So those are all noted in that case, and then that brings us on to the declaration of interest, which is paper B in your packs that you should have received, and it's really there an opportunity for you to make sure you update that, and there you have any declarations. Beyond that, are there any declarations that anybody needs to make us aware of in relation to any items on the agenda? No? Okay, great. Thank you very much. I mean, these are always circulated in advance, and it also, please, if you haven't done it for a while, if you're like me, it's always good to revisit and review those declarations and make sure that they're updated. That's really helpful. And then we've got in your pack again minutes of the previous meeting. This is paper C, the meeting that was held on the 2nd of October online. First, in terms of accuracy, for those of you who were present, you're happy to sign those off as an accurate set of minutes? Excellent. And in terms of the any matters arising from that, anything that anybody wants to pick up? No? Okay, great. Thank you very much. Just for information, if colleagues are wondering, there was no actions outstanding from the last meeting. I believe that's correct, Joe, isn't it? So therefore, that's why that wasn't circulated. So all actions that were sorted out prior to that. And then if there's no other matters arising, we'll move on to our first session, which is the Governor's Matters. And I believe we're with a Governor's Story, which is with Marcella Day, which is a public governor from Daventry and South North Hants. And I believe, Marcella, you're taking us through that. There's some slides that you want to share. We're really looking forward to that. Tracy.
Marcella's just having a few technical issues getting into the meeting, so we may want to take Richard's item first, just while we get Marcella into the meeting.
Yeah, happy to. Oh, thank you. I must have missed that in the chat. My chat.
Oh, hold on, she's just joined. So
okay.
Let's just check she's in the meeting. Yeah. Marcella, can you hear us?
Yes, I can hear you. I hope you are able to see me now. I'm not too sure what's happening this morning.
Well, we can certainly hear you, Marcella. I'm not able to see yet. Does anyone else able to see Marcella?
Okay. Is it on now? Oh, it's. Oh, I'm sorry. It was on earlier, but for some reason, there seemed to be a challenge with me getting my camera on.
Ah, that's a shame.
I keep turning it on, but it it seems to be giving me a problem, and I can't account for the reason.
Okay. So my technical ability to guide you from here is going to be limited. Are you able to email your presentation slides?
I think that Joe already has it. The team
Oh, you've got
already
them,
Yeah,
has
Joe.
it.
we've
Okay.
got the slides, so I can share
Okay.
the slides. If let me just do that for you while you sort your camera out, Marcella.
Yeah. Let's get to the Marcella's slides up. So we're taking a governor's story. And Marcella, if you could talk us through the slides. Are you able to see the slides at your end at least?
I'm waiting to see it.
It should be on the screen now, Marcella. Can you
Yeah.
see them?
We can see those. Can you see those, Marcella?
Yeah, I
Yeah.
can.
Okay. Great. Lovely. Right. You take us through.
Okay,
Just
so sorry about my camera.
no
I was on
problem.
earlier,
These
but I
things are
won't
sent to
keep you up.
tries.
Yeah.
Over to you
I won't-
then.
Thank you so much. And apologies once again. So sorry for not being able to show my feature, but I do have a picture of myself on the next slide. So next slide, please. Okay. So what motivated me to become a governor? Well, it was just over 3 years ago in the heights of the COVID-19 pandemic that I was awakened to the reality that disproportionate health outcomes across populations is not necessarily biological, clinical, or familiar, that is genetic, but they are predominantly due to what is referred to as the social determinants of health. I believe it is still within all our collective memory, the increasing the numbers of losses of loved ones, people known and unknown, and then our health professionals on the front lines, and notably the startling statistics of comparatively significant losses of ethnic minoritized medical personnel and staff. I could not understand this at first until I realized that the pandemic mainly highlighted what was already a pattern of systemic and structural health inequalities. Around 40% of our health outcomes are due to social and economic factors such as housing, employment, and education, among others. These factors greatly influences people's health far more than any individual lifestyle choices, such as alcohol consumption, diet, smoking, or any other factor that people can control. And in addition to this, these individual health behaviors themselves are also shaped by the places and environments in which we live. With this realization, I began my own research, examining health inequalities through my own training and expertise in place branding. And this led to my first conference paper on why places and people matter in tackling health inequalities. And more recently, in 2024, a study on women walking and well-being, engaging place-based participatory action research to tackle race-based health inequalities in Northamptonshire. But that was my role as a scholar, as a researcher. But then what could I do about it personally? I asked myself to make a meaningful difference. That led me to join Health Watch in 2022, where I was appointed to the role of Equality, Diversity, and Inclusion Lead on the advisory board. And so began my activism, that is, working as an advocate on behalf of local communities in addressing issues of structural inequalities embedded in healthcare delivery. This accounts for me here now as a public governor for Daventry and South Northants at NHFT. When I saw the advert on social media, I applied for the role and clearly stated what my focus and representation would be on being a voice, representing the voice of the local community as a social justice advocate for racial justice and also for gender equality. Next slide, please. So this past year in this role has been an eye-opening journey for me. It's a learning, and I'm really enjoying just finding out more. And of course, as somebody who, was in academia, it's all about understanding the range and complexity of the Trust's operations and service. And I do feel quite privileged to be here, particularly now, just hearing earlier this morning as well, with the designation of NHFT as a high-performing trust. However, I believe that my background as an academic and as the co-lead for the Global Ethnic Majority, which is the BAME staff network at the University of Northampton, that really launched me into EDI advocacy, but it also importantly honed my skills in evaluating and analyzing and also designing EDI policy and practice. But above all, as a participatory action researcher, I've been engaging with various community groups. I'm currently wrapping up a project funded by the Research Engagement Network of the NHS that I've named Parity, which stands for Participatory Action Research for Inclusive Health and Transformation year-round. And this involves understanding the lived experiences, mainly of inclusion groups, such as ethnic minoritized communities, the homeless, and those in contact with the justice system. A major component of Parity Project is the training and upskilling of local community and voluntary groups on how to implement participatory action research methods in their intervention projects. And also, it involves encouraging ethnic minoritized groups becoming more involved as well in clinical research. I'm pleased to say that as an outcome of my Women Walking and Wellbeing research, there was a formation of the Ladies Step Together Working Group, and in November this year, we have recorded 3 years now running. Next slide, please. I've just completed my 2 pledges for the year, which I'm happy about, in taking part in stakeholder panels and also in contributing to the Members magazine. Other activities that I've undertaken as a board member is the attendance at the Anti-Racism Workshop in Kettering, a service visit to NHFT Continence Unit, and I also attended the Doctors Awards at Berrywood Hospital as the Public Governor representative. In relation to the Thrive aspirations of the Trust, I'm most passionate about working with and contributing to healthy communities in terms of responsive, including everyone, and valuing our people. I think these are all aligned in terms of me going forward with the focus that I have will be in my role, would be how these goals are aligned in terms of the current policy direction and priority shift towards the hyperlocal, that is neighborhood health. This also sounds so wonderful in terms of its expression in word, but I believe that if implemented, this definitely promises so much more for us all in terms of achieving health equity. And next slide. And thank you so much for listening. And this is just a picture of the Step Together working group. We meet every month. And thanks to one of my public governor member, Pete Spink from Space to Talk, who really supported us in getting this group off the ground. So thanks for listening. And apologies again why my camera decided not to work with me today.
No, these things happen, Marcella, but thank you very much for sharing your slides, and you came across very well in terms of sharing the journey, your passions, and your reasons for becoming a public governor. So a thoroughly informative session. Thank you for that. So any questions or comments or any points of discussion for Marcella? Mabel.
Thank you. I loved your presentation. That was absolutely superb. I think that it would be really nice if us governors could get together and discuss what we're doing, when I used to be a governor at KGH, we had general governor meetings, and I think it would be nice if we could do something similar. But I thought it was absolutely superb what you were doing. Do you do anything on nutrition or on sustainability?
Well, to be honest, not at the moment. Haven't focused directly on nutrition in terms of the projects that I've worked on. However, going forward, I'm hoping that perhaps with the Women Walking and Wellbeing group that I'm currently engaged with, that there will be an opportunity to explore some of these other issues in relation to women's well-being. So yes, there's exercise, but there's also the nutrition component of it as well, which hopefully we can continue to explore. As part of that particular research, however, is just to say it was a walking methodology. So what it meant was that as we walked, we talked. So what I could then say, it was really participatory in the sense that while I was gathering data, I was also assured of the fact that my participants were benefiting from engaging with me as a researcher. And that, in essence, is the nature of participatory methodologies. That's while as a researcher, while we're engaging with our participants, they're also afforded the opportunity to be empowered. So introducing notions of nutrition and sustainability should be well within the remit of that. I'm also working in a couple of months coming up for next year on a project looking at women and climate change. So also how issues to do with climate change and the environment do affect women's health. So it's in the works. Thank you for that question.
Thank you. I think that's fascinating. The reason I ask is because I had been asked by various groups in Northampton to provide information and expertise on aspects of nutrition, particularly diabetes. So if I can help in any way, let me know.
Sure. Thank you so much.
Thank you for that, Mabel, and thank you, Marcella, for your response to that. And again, just shows the example and the power of this kind of governors group coming together and being able to learn and share, and also from that stimulate other actions and opportunities for joining up. Thank you, Mabel. Brian.
Thank you, Marcella. Thank you, Pfizer. I just wanted to, from a research point of view, Northants has a very, very active wellbeing walk program, approximately around about 120 walks per week. And I just wondered whether that might be a source of research data that we could perhaps link up together. I don't know whether you'd be interested in that, Marcella. It will give you, I would think, quite a large cohort to draw information from.
I'm sure. Thank you so much. I think that's a wonderful opportunity. And just to say that I think we have more or less incubated another group in the north, which is the WACA Ladies Walking Group as well. And yet that does give us a better understanding of the landscape in terms of Northamptonshire as a place. Because what I'm beginning to find out, what I'm beginning to tease out from some of the findings coming out of my research, is the notion that certain factors that normally perhaps were more linked to some race-based factors could possibly shift when you look in terms of another place. We're not seeing necessarily a consistency. So some things that we perhaps may think is just about differences across different racial ethnic groups may be more attributable to certain factors within particular locations. And I think that's an interesting kind of direction to continue to explore that would be beneficial for the county on a wider basis.
I'd certainly, excuse me, I'd certainly be happy to, through Tracy, connect you with Julie Cardwell, who's our head of leisure, and perhaps we can sort of tie up that. I think it's an opportunity that we could take forward.
Thank you so much. Indeed, Councillor.
Thanks, Brian. And we'll capture that action so that the links are provided so you can follow up outside of the meeting and help to join up this these kind of opportunities, which is exactly why we do these sessions. Sachin, I saw your hand go up and then you've disappeared. Are you still there?
I was going to make the offer to Brian that, it would connect him to Stephen Zingwe, our head of research and innovation.
Sachin, you're really quiet. Is it just me? I can't hear you very well.
Just give me 1 minute.
Okay. Great. Well, Sachin does that. And Sachin's our Deputy Medical Director and deputising for Itai, who's who noted his apologies.
Yeah. Can you hear me better now?
Yeah, loud and clear, Sachin.
Yeah, so I just wanted to say, if Brian wanted to send me his contact details, I can put him in contact with Stephen Zingwe, who heads our research and innovation department, and we can see.
Really?
And we can see what we can set up moving forward. Yeah.
Yeah, great. Thank you. Thanks very much, Sachin. A link up with you. Any other questions or comments for Marcella? No? Okay. Well, Marcella, a really informative and very interesting presentation. So thank you for sharing that. And some of the things you were sharing and talking about reminded me of a project that I was involved in on the periphery many moons ago in another lifetime. It was called Knit and Natter, and it came together as a group of not just women, but there were men who also were knitting, came together in a community library in the West Midlands. And it came together as a social group, but from that social group, it actually amplified in and grew into a group of health and well-being that then took on a health aspect, a nutritional aspect, and from that it grew into a community organization that then had a spin-off of a social enterprise, which was hugely and immensely contributing to the health and well-being of a whole range of people, from young mums to the elderly, and from that group they set up a befriending. So it just shows from small little acorns what can emerge. So thank you very much for sharing your story in your presentation. So and hopefully I believe those will also be circulated to colleagues who weren't here, so that'll be great. So thank you very much to you, Marcel, and thank you for everybody participating.
Thank you, Faisal.
No, you're welcome. If we then move on, I'm not seeing any other questions. We've got item 6 on the agenda, which is the Council of Governors report, which is labelled Paper D, and it's in your pack. And this is with you, Richard.
Thank you, Faisal. Good morning, everybody. Sorry, I'm slightly off camera. That's one of the quirks of this particular meeting room, so that's perhaps to your benefit. But hopefully, whilst you can't see me, you can hopefully hear me. Indeed, as Faisal's mentioned, we've included the slides in the pack, so I won't draw out all of the details, but we'll highlight probably 8 or 9 things really that I think are perhaps worth commenting on this morning. So as alluded to earlier on, we've had some changes to the Council of Governors since our last meeting. So I just wanted to offer my thanks to Sheila Begley, who steps down as a staff governor. Sheila's made a significant contribution to the council, particularly as the outgoing chair of the standards group. So thanks indeed to Sheila, and indeed welcome to Lisa. I don't know whether Lisa's here today, but certainly Lisa is a well-known member of staff within NHFT, having been the lead for our suicide prevention work for some time. Indeed, Governor colleagues may have met Lisa at the annual general meeting of the Council of Governors, where she premiered earlier this year. So welcome to Lisa. We can see this month there's been a tremendous amount of activity that governors have been leading themselves. I dare say, incidentally, this is only a small proportion of that in the report. So really use this as an opportunity to say to governors, if you are out and about doing work on behalf of the trust in your governor role, do let us know, and we can feature some of your work in a future report. As you can see on the slides, we've got a number of entries from Marcella, who we've just heard from. So both Marcella and Mabel supported our recent Quality and Doctors Awards, an important annual opportunity to recognise the contribution of staff right across the organisation in support of our Thrive strategy. Similarly, Chris and Marcella have been out visiting services with our NEDs and executive directors, and we can see some of the findings of those service visits set out in the report. So again, a reminder to governors, if you are interested in accompanying one of our NEDs and execs out on a service visit, do let us know. We have struggled with a number of opportunities, but I do believe that we've got some more coming up. So if you are interested, do drop us a line at the Foundation Trust mailbox, and we'll hopefully connect you up with a service visit opportunity. So moving through, we've also had, in addition to individual activities, a series of group activities that we've been engaged in. So we can see that we've had a member webinar, this time on both working carers, and a separate webinar on our armed forces. We've included some snippets, really some highlights from those workshops in the pack. But I would encourage you, if you weren't able to attend, or indeed even if you were and wanted to catch up, you can view a recording of these webinars actually on our Trust YouTube channel. It's a really good opportunity to link with members as well. So for governors that are interested in participating, again, do let us know, and we'll give you the details of upcoming events. But we had a fantastic opportunity really to hear about some of the work that we're doing in conjunction with Northamptonshire Carers on supporting carers. So that's the first of the two events. And the other event, which is a little bit later on in the pack, was a workshop that we held actually in partnership with the University Hospitals of Northamptonshire. So as Mabel actually referenced, we're working quite closely with the KGH Council of Governors, and had the opportunity to join up in November to do a webinar in support of our military personnel and service community. So we can see a bit of a write-up in the pack there. Thanks very much to those that took part in that. So we also, in addition to the webinars, held several meetings. So we used the recent Governor and NED constituency meeting actually to explore some of the work that we've been doing as part of our Equality, Diversity and Inclusion programme. So thanks to Summer, who I think is on the call this morning, and Heather, who may not be, who led us through a really interesting presentation actually in relation to EDI, showcasing our work during Black History Month. And then again, on the theme of working in partnership, we held a membership engagement and representation committee in common with KGH. This is where we started to explore actually how we could work together on our membership work across the local community. I think we recognise that very often we tend to work in silos by virtue of our organisation, and actually when we're talking to our local communities, quite rightly, they expect to talk to the NHS rather than to talk to a portion of the NHS represented by a given organisation. So a really positive first meeting, I think, between the two organisations, committees, and I think that will spawn some future work together as we progress through the remainder of the year. So I won't do too much more talking, but I did want to highlight before bringing other colleagues in that as we head over into the fourth quarter, the final quarter of the financial year, we will need to go out to governor elections. We can see here on one of the latter slides in the pack a timetable for the elections, which will launch all things willing at the end of January. And we can see that we've got 8 seats up for election, which are listed there in the pack. And then finally, just to profile, as we would do usually, some upcoming meetings and dates for your diaries. But as I say, thanks very much indeed for colleagues that have contributed to what I think is quite a wide array of activities that have been happening since the last meeting. and I'll hand back, Faisal, to you for any questions or comments actually from the council or any of the board members. Thank you.
Thank you, Richard. A very comprehensive report in the papers. Richard, so thank you for that. And I must say, I mean, I've joined a couple of the governor's meetings as an observer prior to taking on this role. I must say I'm absolutely incredibly impressed by the variety, the range and the depth of some of the work the governors and colleagues have been doing together and in partnership with others. So really excellent. And you've got a programme of meetings and dates within the pack as well for your information for the next few months, which is great. Over to you, colleagues, for any questions or comments to Richard. Is that you, Carol? Did you want to come in?
Sorry, no.
Oh, okay. I saw you come off. I thought you wanted to speak. I think, Richard, you've given them such a comprehensive run through the report, and it's covered everything in detail in the report. I must say, I thoroughly enjoyed reading the report and the slide pack, because it really gave me a good sense and introduction to all the great work that the governors are doing. So thank you for that, Richard. So I'm not seeing any more questions or comments. Just a message from Tracy that's been posted in the chat box is that just in terms of your information, if you've not seen the chat box, a couple of the December meetings were stood down as they were not needed. So one was the standards group and one is the governor's nominations and remuneration committee meeting. So please, if you've still got that in your calendar for any reason, please make sure that you take those out so you don't be turning up to a meeting that is not taking place. With that, we'll move on then, Richard. So thank you for that. In your packs, we'll move on to item 7 on the agenda, which is the update from the chair and then the chief executive. As Angela is on leave, we have Dave Mayer with us, who is our managing director and deputy chief executive, who's acting as the chief executive for Angela. So first, I will always, for purposes of these reports and papers, assume all papers have been read, but I will always draw out a few highlights and likewise ask other report authors to do similarly. In terms of the chief executive's report, if I start with you, was it my report first? So mine's gone in a. It is mine. Thank you for bearing with me. I just pressed the button. I thought it was Dave. I was papery, and it's not. I'm papery. So start with me. So just in terms of some of you will be aware that we said farewell to Christy Waring, who's been the chair of NHFT, but also the group for the last couple of years, but much longer at NHFT. We said goodbye to her in October. She's left the organisation in a very good position, and I'm incredibly pleased to join all of you in NHFT in my interim role. We've got a number of key items that in terms of you will possibly be aware of. In terms of the non-executive changes that we've got, Jo Lancaster is currently an associate non-executive director at NHFT. From the beginning of January, she will be a non-executive director. And we've already talked about Lisa, who's taken over from Sheila Begley as a staff governor. And we've also got, for your information, a number of things that we are working on in terms of succession planning. A few changes. Melanie Hall, that you will all be aware, who's a senior independent director and non-executive director, is from January going down to an associate non-executive director. So we retain her wonderful experience and skill set within the organisation. And Judith Seymour will be taking on the senior independent director role, and they've both been working very closely together to ensure there is a very smooth handover. And Robin Burgess, who was going to finish at the end of this year, has very kindly extended his tenure till the end of March, partly because with a new chair coming in, I'm incredibly appreciative that we have a bit of consistency in our non-executive team. So that's really incredibly helpful. There's been a number of visits and meetings that I've been involved in, both locally at NHFT, but also with our university colleagues, the Integrated Care Board, national chairs and chief executive forums. There's been a number of key discussions, but I will take the report as read. And also you've got an appendix with the report, which is all the activities that of all the non-executive directors, including myself as chair. If there's any questions or comments, or any of the non-executive directors who are present today want to highlight anything, then please raise your hand, let me know. Otherwise, I will open up to questions or any comments or any clarification colleagues would like. No? Okay. I'm assuming from that you're all very happy with everything that's in the report. Again, I will hopefully get a bit sharper at these, making sure that you share with you the key things. Just as an aside, I was in a which will be of interest to governors in the main. Particularly, I was at a national chairs and chief execs session, and the value of governors and the kind of expression that was mooted, that what is the future of governors, was picked up in a national discussion. And the reason I want to share that with you, it's very much at the forefront of chairs and chief executives. And the thing that I'd like to report back from that session is, one, we don't know anything more at this stage other than the status quo prevails. Anything that is likely to change will require legislation and act of parliament to make those changes to the Health and Social Care Bill, which we don't foresee happening for at least 18 months to 2 years. And the third and final thing was that all the chairs and chief executives in the main in the discussion all came to the conclusion what value governors bring to organizations, but also if for any reason things change in the future, that we would want to engage with a wider range of stakeholders, including key to that would be at the heart of it, governors. So I hope that offers a little bit of reassurance from the national discussion. If there's no other questions, if I can highlight, oh, I've got something in the room. It's either Richard or Julia, I think, in the room. You're so small, I can't see on my screen.
Sorry, it's Julia. Just to say, Jo's also here as well, but you can't see her either. Sorry, Faisal, it's a bit late to come in, but I just thought, I've just been reflecting on both the report from Richard and your report, and just thinking about service visits generally. Just wanted to say, actually, what a huge amount of activity from governors recently around service visits. And I think it's really appreciated by our teams and certainly by ourselves as non-execs, because it gives a completely, impartial, different view in, I think, to our services. And that triangulated with the non-execs and our execs that visit, brilliant. And it's just so good. I wanted to recognise that activity. But also just to say that in the public board, I mentioned I've been on a whole day round robin visit schedule with Anne Rackham, Chief Operating Officer. We didn't have a governor with us. We had quite an intense day from crack of dawn till quite late. But we did go round all 5 of our newly reconstituted community mental health teams. And that was on the back of, for me, seeing a lot of assurance through the Quality and Safety Committee around the work of these teams. It reflects back to the Nottingham report that people may remember, Nottinghamshire Community Services with some real challenges in their community mental health teams. And we see at the Quality Committee all the assurance about the action plans and everything that's going on. And it was a fantastic opportunity to directly talk to very many staff that day who were very open and honest about the transformation and the work they're doing to improve services for people of Northamptonshire. And they're at various stages in the transformation work. But the overriding theme that came through is they're over the initial sort of, it's all very difficult when you reform and change caseloads. But absolutely everybody we spoke to was in it for the patients and the service users and trying to make things different for and improve services. So just thought I'd add that in. It was a big day. Apologies there weren't governors there, but actually it sort of balances, I think, with some of the visits that the governors have been doing. So thanks very much.
Yeah, thank you for that, Julia. Thank you very much for highlighting that, and also the importance and the value that governors add to those visits, and their contributions are incredibly welcomed and also valued. Mabel, you're on mute.
Is that better?
Yes, we can hear you.
Thank you. I'm so pleased you brought up about service visits, because I've not managed to go on any official service visits since I've been appointed as a governor, and I find that very frustrating. I have visited departments like the catering department at Berrywood because I was invited there when they got their Soil Association award. But being a governor at Kettering, we used to be able to go anywhere and everywhere, provided we wore our badge, we were appropriately dressed, and also obviously we informed everybody that we would like to go. But I feel that it's very different here, because it's only to accompany a non-executive director or a director. Can governors go where they want to, provided it's agreed?
I'll bring in Richard in a moment, but Mabel, thank you for the question. I think different organisations have a different approach to visits. One of the things we do try to do at NHFT, but also in LPT, is we try to ensure that the same areas don't seem to get an influx of visits from individuals from the board, and in NHFT's case, governors. So that's one of the reasons we do it, pair up people with an executive or a non-executive director to go to those places. Secondly, it also ensures that we're able to track who's going where, and also the feedback we then get from those visits is kept. And if there are anything that we need to follow up in terms of actions, that's being tracked, etc. What I certainly would ask you, Mabel, to do is liaise with Tracy and or Joe outside of this meeting, and let's see how we can organise. But what we don't want people doing is, particularly because of some of our areas are restricted areas, we want to make sure people know when you're coming. It doesn't put pressure on staff, and not anything else more than that, which is making sure that our patients and the communities that we serve are feeling that they aren't being inundated with visits from external. So please bear with us, and please do reach out to Tracy, and we can make sure that we can liaise with colleagues to put you through to service visits. And I'm sorry it's been a frustrating time, but let's see what we can do. So we'll take that as an action to pick up, Mabel. So I hope that's okay.
Thank you very much. Tracy's been fabulous when I've asked about visits. At KGH, people were never inundated. One person or possibly two would go at a time, and often it would be situations like people would say to us, we've not seen you in pharmacy or whatever. Oh, I wish you'd come and visit. So it was almost an invitation to visit from the staff in that department. But I'll look forward to visiting more in the future. Thank you.
Thanks, Mabel. Richard or Tracy, or Joe, anything you want to add to that?
I think you've covered the main points there, Faisal. We'll certainly work to get an opportunity organised for you, Mabel. Sorry you've been having difficulties getting a visit organised, but certainly with Tracy and with Dave's team, we'll identify an opportunity for you. Thank you.
Thanks, Richard. Just to highlight before we move on to Chief Exec's report, we've also got in the chat box a message from Tracy that in January we'll be holding the election for the governors, because I believe there's a third of governors that will be due for election. So please keep a lookout for all the material related to that to make sure that we promote that as widely as possible to encourage people to understand the value and the role of governors and what they bring to in terms of public connectivity and public accountability to the work of NHFT. So that's will be very much welcomed. Without any further ado, if I could bring in Dave Mayer as our Managing Director and Deputy Chief Exec in place of Angela with the Chief Executive report. Dave, over to you.
Thanks, Faisal, and hello, colleagues. So just a few updates and taking Faisal's lead on papers as read. And the report is in the pack. So I'll just pull out some key themes. The first one, I guess, is the Advanced Foundation Trust status, which we've been asked as part of the 10-year plan, the NHS kind of reform plan for foundation trusts, of which we are one, to become advanced foundation trusts. And we're going through the process led by David Williams, our Group Director of Strategy and Partnerships, to submit our application as part of that process. There's no guarantees, of course, as part of doing this, but it is noteworthy and a commendation to colleagues for us being asked in the first place to apply and become a pathfinder in that sense for the NHS more generally. So that's really positive, and we're one of a small number of mental health and community trusts supporting that work. If successful, that will allow us to look at holding an integrated health organisation contract, which is detailed in the report as a population health management contract that allows us to hold a budget for a defined population within a geography to promote better health and well-being within that community, and also seek to manage health needs in a more proactive sense, aligned to some of the work that we had from Marcella earlier with the presentation about health equity, etc. It helps us to do that using all of the budget available for that population to drive better health outcomes. And that'd be really exciting and positive for us as an organisation that provide cradle to grave services, being able to have the full spectrum of resources potentially to support health management is quite exciting. So more on that as we go through the process. We're also in the middle of planning for what initially would be 26-27, but for a 3-year period, and we're developing plans which will come back through Council of Governors as they did last year as part of our Thrive strategy. So more on that in due course, but fair to say it's absorbing quite a lot of teams' time currently. The timescales are pretty tight, and we've got a session this afternoon with the board on just where we've got to with some of that, with final submission in February of next year. We're waiting on final budget settlements from our ICB commissioning colleagues to describe the resource that will be available to us. I've just come off a national call for mental health trusts in relation to funding going into the mental health sector. They are keeping what is described as the mental health investment standard, where the expectation is that investment in mental health will grow commensurate with growth in the NHS more generally. And that was a big improvement to how mental health trusts were funded. But however, growth in the wider health sector is quite minimal. It comes with caveats in terms of what that will mean for us. But it does at least give some policy context to mental health in relation to parity of esteem and those things that I think are really important to us. And back to the equity point from the earlier presentation, really important that we're able to be seen as equal with the rest of the NHS. The Quality Awards Richard touched on, which were fabulous, as were the Doctors Awards for those who were there. It was just lovely and warm, as I said, at the board. Just in terms of some operational updates then, we've had 10 additional community hospital beds opened as part of our Spinneyfield work in Rushden, which again, Council of Governors will be aware of. That gives us a really robust way of heading into what is going to be quite a pressured winter. We're already seeing some peaks in flu and wider seasonal kind of diseases kind of in our community. And I know Brian will be keeping an eye on that through the Health and Wellbeing Board structures. But that's really important, and it does allow us also to manage length of stay better with our communities that are using our hospital beds. So that's a really welcome addition. We should celebrate that. Our school nursing service also marking 10 years of mental health support is really important, not least because as part of the NHS 10-year plan, there is an expectation for all schools to have not only good nursing services more generally, but equally mental health services in schools. So that's an important milestone for us and an important milestone for the NHS, I think. And just finally on some of the operational updates, Faisal, we have begun providing healthcare at HMP Ranby, so our secured services, which we're taking on through Knots and Links. There'll be more coming on stream in Q4, and we're seeing really good feedback from staff who've transferred to the organisation. They feel engaged and optimistic about the future and the opportunities of working as part of NHFT's suite of services and our provision of secured services nationally. We've also had the HSJ award, so commendations to our provider collaborative, our CAMS provider collaborative, which is led by NHFT on behalf of the region. We were awarded Collaborative of the Year for the work we're doing supporting children and their families to receive intensive mental health support without needing to use beds. And that's a really important recognition of the work we're doing to keep people at home with their communities, with their families, and only really needing to access those intensive and quite kind of, austere beds when they really need it. And to get that recognition, I think is quite important. So thank you again to the team for all they're doing in that space. Thank you also, Faisal. Note that you've taken on the role here in the report. So warm welcome to you from the Trust Executive. Thanks.
Yeah. Thank you, Dave. Thank you, Dave, very much for your highlights from the report. If I may, just before I bring in colleagues for questions, two things I just want to draw out, Dave, if I may. One was that last week at the public board session of NHFT Board of Directors, we also had a presentation from colleagues on the secured provision in prison services, and we had an excellent presentation talking about particularly around women's health in prison and the Women's Hub that has been set up in a number of services where we provide services. And the overwhelming presentation was absolutely wonderful about how we're supporting that cohort, and quite often the understanding of the people in prison are there who deserve it. But one of the things that came across was the health disparities, health inequalities of the women in a number of prisons and on remand, who are quite often the victims of crime and victims of other violence and domestic and physical abuse. And it was really a wonderful presentation to receive that, and listening to our teams who've done the work there. And again, joining with Dave in his report to say wonderful to the work around the collaborative and the HSJ award. Again, it's a great accolade, but it's a recognition of the work we're doing with those cohort in our young people and adolescent community. And then finally, I just wanted to say I felt a bit of an interloper, having only completed 1 week of my role as interim group chair at NHFT, but I managed to end that week with the celebrating a quality award session. It was just absolutely wonderful for me to be there. All the hard work that's gone on behind the scenes, our sponsors, our communications team, but importantly about the work what our staff do every day, going above and beyond to provide those services to our communities in Northamptonshire. So it was a really great event, wonderful to be there and to hear more about the great work that takes place. So thank you for that, Dave, for sharing that. I just want to add a couple of those points. Yeah. If I bring in our room, they'll tell us who in the room wishes to ask or make a comment.
It's Julia again. Just a
comment.
Julia. Hello there. Just a comment, thanks Faisal. You've already the first one you just mentioned, that it was around the quality awards, because what I just wanted to share with governors is the appreciation in the room from the staff, from all the different teams, and the excitement was absolutely incredible. So I was also going to say thank you to everybody that organised it. But I think if you haven't attended, they are well worth attending, just to talk to so many, 200 odd people in the room, every single one of them appreciating each other, and hearing from us as a board as well of the work that we appreciate too. Phenomenal event. So I was going to share that. But Dave mentioned the Doctors' Awards, and that was actually an inaugural award. We haven't had that ceremony before. And again, it was doctors and dentists, small workforce group within NHFT, but absolutely vital, obviously, to all our services. And again, their appreciation of just being recognised. Dave mentioned warm, lovely feeling. It absolutely was. And I just couldn't let that go without just saying, again, appreciation to everybody that had worked hard to make that evening a success. The staff themselves, just to feel part of that and feel more connected with the organisation and with us, was phenomenal, and you couldn't underestimate that. So just thought I'd bring those two out for us. Thank you.
No, really welcome your comments, Julie. And I think sometimes in time of huge financial challenges, you can often hear people say, NHS staff, going up for a knees up, I'm using kind of reasonably pejorative and kind of colloquial language. It's not a knees up. What I saw was hard-working staff being recognised for the work they do every day. And it generally was about people who go above and beyond. I think for one evening to recognise our staff, funded and sponsored by a whole range of partners, so it doesn't come out of NHS core budgets whatsoever. I think it's an amazing, and I think, Julie, on your point, I think the energy that emanated from that room for all of us who were there to feel that, and they could then go back to their work and their colleagues. And for those who've not been nominated, encourage them to be nominated and do that work. I think it's a huge, huge opportunity. So I'm all for those things because of the calibre of the messaging it sends to our staff and our people, that we care about them and thank them for the hard work they do every single day. So thank you for that. I'm not seeing any more questions. Oh, Brian, if I can bring Brian in.
Yes, thank you, Faisal. Not to wish to labour yours and Julia's point, but having spent a lifetime in organisational development, I just wanted to reinforce the importance of those activities in terms of creating a sense of belonging and purpose for people. When times are tough, those sort of things you can't really measure in pounds, shillings, and pence. So I just wanted to endorse that and encourage you to continue to do things like that, even against some of the rhetoric that you may face.
No, thank you, Brian. I completely agree. So thank you for your comments of support. Anything else for Dave in terms of Chief Executive's report? Any questions or comments? No. Well, thank you, Dave, for the report and also deputising for Angela. And please, thank you for drawing out some of those key highlights. With that, we'll move on to item 8, and this is the non-executive director risk and assurance topic, which is covering digital services. This is with Judith and Natasha, who've got a set of slides to lead us through. And over to you both.
Thanks very much, Faisal. Good morning, everybody. As Faisal introduced, Natasha and I are going to be telling you a little bit about the digital services and what it is that we do here at NHFT, how the non-execs, how we get our assurance, and where it's all going to be going to, what the outcomes are going to be. And the reason why we picked this specific topic to talk to you about today was because it's the digital services and the digital strategy that NHFT has. And in fact, it sits at group level, so it's the same across LPT as well. It influences the 3 shifts, and is actually very much part and parcel of the 3 shifts which are required by NHS. And before we go to the next slide, the other thing I'd like to say is I feel very privileged to be talking to you about this today, because behind the scenes there is a very genteel bun fight between the non-executives as to who gets to talk to you about their specific, pet subjects. And as you know, I chair the Performance Committee, and the digital services report up via Performance Committee. So this is actually very close to my own interests. Thank you. Tracy, can I have this next slide, please? So I'm going to have to apologise for the first 4 or 5 slides, because they are not only busy in words, but they're also busy in images. So I'm going to sort of step you through. I'm sure you've all heard of the NHS 10-year plan and the 3 shifts that are encompassed within it. The first being hospital to community, to take patients out of acute, ensure that they don't actually go there in the first place because their illnesses have been caught earlier, or they are discharged into the community and are supported in their own communities from a healing point of view. The second one is where I'm going to focus, which is the shift from analog to digital. So rather than, for instance, using paper records, which I hasten to say we don't in NHFT, we use, for instance, the NHS app, that we used digitally enabled applications and databases to make sure that the service that we offer to service users and patients is seamless, and that they don't have to repeat everything 16 times depending on who they speak with. And the final is treatment to prevention, which frankly all links in with hospital to community and analog to digital, and speaks to itself. The one thing on this slide that you may not be familiar with are the icons on the bottom, because these 3 shifts are underpinned by the 5 big bets. And the 5 big bets in order, and the first one is data. So everybody within the NHS has to focus on improving data quality, timeliness, and accuracy. The second one is AI, how the push and the need is for integration of AI into clinical pathways to improve productivity. The third icon is genomics and predictive analysis. So the idea here is to use predictive analysis and genome science to shift healthcare towards preemptive and highly personalised care. And it also links, obviously, to prevention. The fourth icon is wearables, which we should all be familiar with, or probably are, because potentially we're wearing a Fitbit or something similar. It's that sort of thing. It's to empower patients and clinicians to really take control of patient care. And the final is robotics, which I know we've all heard in relation to acute hospitals and serious operations. However, there are a lot of technological developments within robotics, and the idea here is to extend this robotics technology into patient support and rehabilitation. So that's on a very, very high level, the 10-year plan and 3 shifts. And what I want to do very briefly is to run you through how that impacts, how we've adapted that into our own organisation, and how we're putting that into effect in relation to digital. Can I have the next slide, please? Thanks, Tracy. So here we have the group strategy. Again, you're very familiar with this, so I'm not going to read all the words out to you. What this slide has done is set out the 6 pillars of the Thrive strategy and the objectives under each of those pillars. And what the red, if you like, letters and words indicate is where technology and where the digital shift actually fits into our Thrive objectives. So as you can see, digital impacts every single one of the pillars. It has its own pillar under technology, but it impacts on all the other remaining 5, most specifically within healthy communities, valuing our people, efficient and effective, because that is where digital can really assist, but also the remaining 2. I'll leave you, you may have already read the slides because they were distributed earlier, so I will leave you with that, but happy to answer any questions later. Can I have the next slide, please? And this is our group digital strategy, and this is what comes to the Performance Committee on a regular basis for review, and it is also reviewed at the group board. And again, we have all the icons explaining which bit touches on which part of the 3 shifts and our Thrive strategy. But here we have 5 pillars as to how at a group level, the digital strategy will deliver not only on the Thrive objectives, but also on that second shift being from digital to technology. So we need to focus initially on the digital foundations. We got to get the foundations right. So basically the data that sits in databases needs to be accurate and it needs to be complete. So that is really important. Then we need to focus on workforce, that the workforce in our colleagues know how, when, what to use. And that's really, really important. There needs to be buy-in from our colleagues in order to ensure that these systems are used to their best advantage. And the same thing needs to happen for our patients, our carers, and also our service users. So there is a pillar under the group digital strategy for that to happen and that work to take place. And the final 2 is really around how knowledge, understanding, and data-driven decision-making to ensure that we understand how all of this work, this using digital enablers, actually provides us with efficiency and quality, because there is a lot of noise, if I may put it that way, around the use of AI. A lot of people, if you ask them, well, what does that look like? What does that mean? How is that going to help? That becomes a bit more of a grey area, and we mustn't just use technology because it's available. We must use it in an appropriate way to support us to deliver better care, be more efficient, and deliver our Thrive objectives. And finally, it's all around leadership and culture, and related to the digital arena. Us at board level, we need to know what we're talking about. We need to evidence that we're using digital in an appropriate way, so that it all, it's an old-fashioned tone at the top. We need to seek out opportunities as to where we can introduce digital in a really clever and efficient way. So that is a group strategy, and as you can see, the little icons on the bottom explain to you exactly how this group strategy fits in with the Thrive model, and how it also fits in with the 3 shifts. Can I have the next slide, please? And this is my final slide before I hand over to Natasha. And this is really about what good looks like. So I've told you about the strategy, but you're probably sitting there, that's great, that's words on paper. What is it that you want to deliver out of this? What are the tangibles? So as you know, the Thrive strategy is a 5-year strategy. And therefore the group digital strategy is also a 5-year strategy, because it's dependent on Thrive. So in 5 years' time, what we have done here is we've broken down, and HFT touches on a lot of people's lives, so we've broken down 4 separate, if you like, segments of stakeholders within NHFT: the executive, service users, patients, clinicians, and DTS and LHIS, NOMAs, sorry, the acronyms. DTS is Digital Technology Service and LHIS is Leicestershire Health Informatics Service. All we need to know is that they're the tech departments in NHFT, and LPT, it's just, that's what they're called. So we've broken down the outcomes, if you like, of the strategy under these headings, so that it becomes really clear as to what it is that the strategy is seeking to deliver. There are a lot of words on this page. I don't want to read it out to you. That's super patronizing, and I'm just not going to go there. If you have a chance to read it, or if you perhaps already read it and you've got some questions, again, really happy to answer, or even revert to you, because I don't have the answers to all your questions. I never do. At this stage, I'd like to hand over to Natasha.
Thanks very much, Judith. So first of all, maybe by way of introduction to myself, for those of you that haven't met me, so I started just 3 months ago as an associate non-executive director for NHFT. So still very new in post. So be kind. Just to say as well, I think my other role outside of NHFT is that I look after digital solutions for a med device company. So obviously digital is something very close to my heart and a key area of interest in terms of how I support and understand how we can move forward at NHFT. Okay, so if we can have the next slide, thanks ever so much. What I wanted to start with is really kind of three big key assurance areas where we as non-execs have really seen fantastic assurance in terms of the digital maturity of the organisation. So the first is the digital maturity assessment that all providers go through. It started in 2022. It's a self-assessment. But it is extensively peer reviewed. So NHFT have gone through a process of reviewing this, not just with their peer partner that they were assigned, which was Nottinghamshire, but also locally with LPT. They've also done an awful lot of calibration, interviews, evidencing their position with suppliers. So really good in terms of them checking their homework. There's over 300 questions they have to submit here. And it really looks at that framework of what good looks like, which is the framework for digital quality that came out after COVID. And in 2024, NHFT had some fantastic results through this digital maturity assessment. They were scored at 2.87 for mental health and 2.93 for community. And those numbers probably don't mean a huge amount, but if I put that in context, that made NHFT the most mature digitally across the whole of the Midlands and in the top 10% nationally for mental health. So that's the first, I think, point of assurance. The second is, again, independent work that was done by the London Procurement Partnership, who have partnered with NHSE and a company called Nuvoli, who are a telecoms company, to offer assessments of the mobile estate, so mobile phones, tablets, that type of thing, and also the telecom systems that support that, the contracts. And they've so far assessed more than 100 trusts and found more than £20 million worth of savings. And NHFT has come out of that, I think, at the last count as the best managed of those. But that doesn't mean that they haven't made improvements. In fact, you'll see it on in a slide, a couple of slides along, that actually they have also looked at new contracts and improvements that have been made to improve connectivity in that space. So it's a huge value coming out of that, even if you're best in class. And the third is really the data security and protection toolkit submission. And I think this is fairly unusual, and the team will probably, some of my other NED colleagues will probably have a view of this more widely, but this is quite unusual, I think, to have a zero follow-up audit recommendations. And this data security and protection toolkit is really there to make sure that NHFT is understanding, and all providers are ensuring that they meet the data guardian standards, the national data guardian standards, and that's really about how data is used and protected, and both by individual staff members and by the organisation. So three really key areas of assurance at the macro level. So if we can have the next slide, please, Tracy. So then what I wanted to do was just talk a little bit about the how, because I think it's my last slide is really talking about the what NHFT has been doing and some of the work that we've seen as non-execs and I've already seen so far. But I wanted to also take a moment to just to share this slide that at a recent performance committee workshop the digital team shared with us, because I think this really talks to the way that the team are approaching the work, both as NHFT, but also with their LPT colleagues. And you'll see compliance is first on this list. You'll see life cycle approach and clinical risk key, outcomes and staff effectiveness, constant review and streamlining, innovation and strengthening digital capabilities amongst staff. And I think those are all really important tenets that guide our organisation in terms of how we go forwards and how we support digital maturity within the organisation and continue to be aspirational. I think one of the other things that the team shared with us at that workshop is actually they have a very significant roadmap, more than 60 projects on there. But what I was also really pleased to see is that there's regular review and a very structured process where the clinical teams come in and are constantly prioritising that roadmap so that the highest value and most important things are being delivered on that roadmap for the trust. And that, for instance, the introduction of the new HMP prisons to NHFT has had to be factored into that roadmap this year. So really seeing that working dynamically already. Thank you. And then I'll take the last slide, which really I just wanted to, Judith and I just wanted to give you some examples of where we've seen this in practice across these three pillars: patient and carer assurance, clinical and operational, and workforce. So IQVIA is a nationally recognised benchmark standard in terms of capturing patient experience, and we've seen those reports now coming in through our committees, and that's been fantastic actually, because what it means is that the scale and the scope of the patient experience is really amplified in terms of what we can hear at board level. Obviously, you'll probably be aware already of the Northampton Care Record and the work that is ongoing there. And I suppose my reflections on that is that we are not at the top of the list for the Federated Data Platform and the national programme. It's very reassuring to see a resilient approach in terms of how do we move forwards with shared care records, and how do we build that integrated digital landscape across the system and the system leadership in this space to make sure that we continue to connect up records and avoid duplication for patients. And then lastly, just a wide-ranging set of improvements that we've seen, and recently joint procurements that have been done between LPT and NHFT, helping to improve cost efficiency. So and then in that middle pillar, you'll probably be quite excited about the robotic process automation RPA piece there. And I think that, and also a couple of other things I'll pull out as well, the policy chatbot and the Magic Notes trial. So those all talk to, I think, some of the innovation work that the digital team are driving. And what I've been very reassured about is that, and assured about, is how the team are approaching that with a let's start small. So they're working in a very much an experimental way, which is a key tenet of how digital should be brought into organisational change. So something I'm very familiar with, and really stepping into learning and understanding and looking at innovation spaces and where they can do that in a very progressive way to build their learning as an organisation and as a team. So this, and just to assure everybody, robotic process automation is essentially just automating tasks that humans do on a repeated basis. So this is directly contributing to staff efficiency, as is the Magic Notes, which is an ambient voice technology, and the policy chatbot, again, staff time savings in terms of being able to find the right information from the policies where needed, and stepping into understanding how AI can be leveraged to build something like that policy chatbot. So really measured, steady approach to some of those key areas. The block below, the update to Windows 11, the endpoint detection and response, and the Microsoft App Locker, again, quite techie terms, but those all talk to the cybersecurity. If I give you an analogy, this is a little bit about like having a house and improving all of your locks and windows and security and lights outside, and making sure there are less places where the attackers can come and attack you, and not allowing things into your house that might be a Trojan horse, etc. So all of those, both national and trust programs that they have implemented that support the cybersecurity agenda. Power BI really being seen in the business intelligence and how we use data. And at the bottom here, the performance on DTAC and some of these other requests. I really wanted to bring this out because this talks to the scale of some of what the trust are dealing with on a day-to-day basis, and the reliability of doing regular work and hitting those numbers in good time. So more than 2,000 subject access requests and freedom of information requests, and really high levels of turnaround compliance there. and more than 100 DTACs. And DTACs are essentially the assessment that you do when you look at bringing in new technology into your organization. That shows the level of, I suppose, understanding in terms of making sure that there's due diligence in how they bring software into the organization. I think also then, just I suppose in that cybersecurity space as well, and in the workforce area, just to mention as well, significant programs obviously in terms of how to reduce phishing and staff susceptibility to phishing. It's one of the key areas for cybersecurity. And I've already mentioned the connectivity work with the telecoms contract. So that's just a flavour of some of the things that we've already had visibility of, and I've already seen in 3 months, which is enormous if you think about it. There's this huge scope of work that is happening at NHFT on a day-to-day basis. And I think it's really important for us as non-execs to encourage the board and the trust to not be complacent about being in a really good position here, but to be aspirational and to be leaders in driving the shift from analog to digital. There's still huge opportunity and also change happening around in terms of ICB changes around system leadership in digital, capital allocations and other elements that have to be managed for within that process. So a space that continues to be, I think, emerging and challenging, but also super exciting, I think, for the trust to see how we can bring this to even more patients and be even more active in terms of how the trust can deliver this. So I'm going to stop talking there because I've also spoken for a long time, and Judith and I will be happy to take any questions that you might have or attempt to.
Yeah. Thank you, Judith and Natasha, for a very enlightening and informative presentation, and hope colleagues can all who are on the call today and those who will view the recording see from this how this links in with the NHS 10-year plan around analog to digital and shows the journey that NHFT is on. And this isn't everything that we're doing on digital, but it's a really good part of that, and there's a huge amount more going on around digital. So thank you for that. Melanie.
Thanks, Chair. Yeah, well, I just wanted to add, if I may, and sort of extend for Judith and Natasha, a perspective from a Ned who sort of sees across both the group organisations of Leicestershire Partnership and Northamptonshire, and not only through the joint, increasingly integrated digital team that we have now across both trusts and the governance through the digital board, but also there is still sort of real strong focus within each organisation through the transformation groups, which routinely review the digital agenda. But what I see across both is a tremendous sort of sharing of best practice, of knowledge. We pilot in one side, it enables faster adoption on the other. And also sort of making a real difference to patients, to service users and to carers and their families. And if I may, a couple of examples that sprang to my mind as Judith and Natasha were talking. Well, not all of them brand new, but some really powerful digital tools being used across both trusts. Simple things, not necessarily really complicated AI robotics, but simple things like chat health, which has been around a while, but the ability for young people to text a mental health service and support, and interact really easily and quickly when they need help. We're seeing the adoption of Isla wound care management, where patients can take photos of their wound care and have better sort of management of their pressure ulcers or whatever the wound may be. We've seen SALT, the speech and language therapy, really adopt digital means of providing interim support and questionnaires to people whilst they are waiting for services, and particularly support for carers and families to provide some some help pending sort of being seen with the therapist. So there's lots of shared learning going on. And particularly as well, shared learning where uptake and engagement with staff isn't going as fast as we might have liked. You know, that it's not all digital implementations are slick and efficient and everyone just goes, hooray, I've been waiting for this all my life. Sometimes it can be quite difficult for staff to adopt new ways of working. So again, a lot of shared learning about how we are engaging with staff and improving uptake and speed and efficiency of uptake. So just a really great integrated agenda going forward. So sorry, just wanted to add that in. Thank you.
Yeah, thanks, Melanie, for that additional context understanding. Anything else? I mean, I wondered, David, are you still with us there? I may have lost a couple of colleagues, but it was just about the thing around in the I think Mark had put into the chat box about AI and notes transcribing, etc. I mean, my understanding, Mark, is from that there are clear guidelines appearing on what and where things can be stored, what applications we can use, etc. And there are some trials going on nationally, so I'm sure that we will fall in line with those and only adhere to those operating systems that are passed through NHSE's processes. Judith.
Yeah, sorry, just absolutely, Faisal, completely agree. Just to sort of add in there that our use of AI to take notes, etc., first of all, is a trial basis only at the moment. Secondly, it is not patient facing. This is much more corporate governance facing. And the reason why that is because we do not want to, we are very, very aware and very conscious and very protective of any data to do with patients and service users. So this is really high level note taking for high level meetings, and we want to just check whether it actually saves time. We don't know yet, so we're very much at the trial stage. And I did actually ask a very similar question to Gareth, who's the head of the DTS, and he said that on an ongoing basis there'll be communications with patients and service users where all of this is made clear, but we're not there yet, so we haven't had to actually do very much of that.
Yeah, thanks, Judy. That's really helpful to have a little bit more fuller response to that. And as you say, we won't introduce things until they've gone through their various approvals. Brian.
Thank you, Faisal, and thank you, Judith and Natasha, for an excellent presentation. It's blown my socks off, I've got to say. I just wanted to something that I didn't see coming through the theme of the presentation was around the importance of communication. And one of the things that troubles me as we move from a more analog to digital services, particularly for patients, is the aspect of digital exclusion. And really, I think I just wanted to highlight the importance of keeping that in mind, that not everybody is as tech savvy as we would like them to be, but also the fact that people have got to understand what's in it for them, and the communication of that is really important. So I didn't see it strongly through the presentation, but I just wanted to put it on the radar, and I'm sure it's covered in all of the other work that you're doing, but we need to bring people with us on this journey rather than do it to them.
Yeah, a good point, Brian. I mean, just to give you some assurance, and I'll bring Judith in before I then go to Mabel. But in our Thrive strategy, in all of our combination of learning from our DigBQ strategy prior to that, digital poverty, digital exclusion is very much at the forefront of our agendas, and how we use that, and to make sure that nobody's left behind, and how do we use that. And actually, one of the things I think Joe's also mentioned in the chat box, in the chat function, was that we're not using technology for the sake of technology. We're actually looking at technology to be where it adds value and it can make things, improve health outcomes. So it's not for the sake of it. So I hope that helps. Judith, I'll bring you in before I go to Mabel.
Yeah, thank you. Brian, I'm so pleased you brought this up because I have a lot of pet subjects. This is definitely one of them. And the reason we actually specifically didn't put it into the presentation, because this aspect is really touching on our health inequalities work. And Dave, I know I have bent Dave's ear on this several times about, it's not only digital exclusion, it's data exclusion as well. Some people are savvy, they just do not have the resources to buy themselves sufficient data to be able to, be empowered to work on that and interact with people on a digital basis. There are national sort of policy attention focused on this from an NHS point of view, and I know that we're influencing that through our group digital strategy and our work with that. We are, through our health inequalities work, we're ensuring that we're not introducing anything to the exclusion of written or other types of communication, text, for example. We also have work around health literacy. So it's all very well digitalizing something, but if people don't actually understand the communication style to start with, then you're just not going to win on this. So there's several strands of work definitely on it. But thank you for raising the point.
Yeah, thanks, Judith. Natasha, did you want to come in that?
Yeah, just I suppose Judith has done the 99%, I think, of what I would have said. But I think also one of the things that I have heard from Anne Rackham as well, in terms of how the trust is approaching business continuity as well, is actually about an and strategy, not an or strategy. This is not about TV replacing the radio. This is about how does digital and a digital access route to care become an option for patients who that is more beneficial, where it is easier for them, where that improves access, where that might improve efficiency for the organisation. But I'm definitely not hearing that there is a plan that this is an only route from the trust. And I think that's important as well, because as you say, this isn't just about our patients being on that journey to digital maturity. This is about the staff as well. They are also on that journey to digital maturity. So actually educating staff in terms of like that very basic, that phishing example, making sure staff are aware when an email is safe to open and when it isn't, is really good for them and protecting the trust, but it's also good for them in their home life. And that's part of a wider education and upskilling that has to happen in digital. And that's why I think experimentation and doing things small and safely, whether that's the AI projects, whether that's the right way to be doing this, because then you build the digital maturity in the organization, and then you can train that out across and take that learning to the other departments and across the group as well.
Yeah, thanks, Natasha. Completely agree and support those comments. Mabel, and then Linda finally. Oh, Mabel, you're on mute. Yeah, we can hear you now.
Thank you. I thought that was a superb presentation, and I'm glad to hear that things are being looked at across the other hospitals. One thing I wanted to ask, though, is are you going to use the little robots like my local co-op uses to deliver things, so that instead of somebody having to go to pharmacy or wherever for something, a little robot can toddle along with it?
Yeah, thanks, Mabel. If I take that as a quick response, I don't think that's on our radar and our agendas at this moment in time. The little Amazon robots and the little co-op robots, but I'm sure as those things become more prevalent and more accessible and more affordable, that'll be something that particularly I would imagine local community pharmacies might be looking at things like that in the near future, but I don't believe we have any plans to do that at the moment. And then if I move on to Linda for the final comment or question. Linda.
Thank you, Faisal. I just wanted to come in with regards to a phased approach to us starting to starting to utilize AI. So part of what we're doing when we look at digital is to listen to the voice of all our service users. We have a very large contingent of young people, and this is one of the ways that they communicate. In order not to exclude them and lose them, we also need to be up to date with what's happening digitally. So we are on that journey as the staff, because this is how our young people will communicate, engage with us. We recognize that there's digital poverty in other areas. We've also got a lot of older people, and that's not the preferred way of communicating. What's useful to note is as we move around to various locations, just an example, a lot of car parks previously you could put coins in just to park. Some no longer have a facility for coins, and you absolutely have to use your phone and app to be able to do that. So part of us embracing technology is not just that there's rollout of equipment, everyone is doing it, but actually there's the awareness raising and supporting people to start to understand that to access other services in the NHS, these may be digital. So we have a role in that, in supporting the users of our services, the carers and the community, to recognize that these are things that they will come across. So some of the information that we provide and share is not just useful to someone accessing services for NHFT, but it will support that individual if they're accessing other health services. So we're starting this in a very controlled manner. As we've said, governance, just some of our meetings, staff, not patient facing, not patient touching. Again, just to see how that works. We've got Caldecott Guardians in the organization, so anything that's going to have to deal with staff will need to still go deal with patients, will still need to go through some robust checks in order to ensure that we are protecting our patients' information and we're not just using it anyway. So we've got those things in place. Hence, we've started with our own sort of internal meetings where we are now starting to try out things, like we said, with our note taking, just to see how efficient that can support us in our work. Thank you.
Yeah, thank you, Linda. That's very helpful to have in the back of our minds and understanding what we are doing and what we're not doing. So thank you for adding that. Look, thank you very much to Natasha and Judith for that stimulating presentation, which obviously led to a good discussion. I hope that's been incredibly helpful and informative. It won't be the last time you will see something on digital. I can certainly guarantee that. So that brings us to our standing items. I've not been advised of any other business, so I'm not intending to take up anybody's time unless there is anything urgent, pressing that somebody wants to draw to my attention. No, great, thank you. So look, it's been a really good meeting. Thank you, all of you, for your contributions, your participation and your attendance. The next meeting is on the 5th of February, and that's at 3 p.m. And just for information, colleagues, that the governor's meeting in private, that was originally scheduled for later today, has been stood down because there was no items of business to discuss. So please be advised that that's not taking place. If you haven't already removed it from your calendars, please do so. And it just remains for me to thank everybody for your contributions. Huge amount of work, wonderful, great work, and the depth and breadth of work carried out by our governors. Thank you to you for all your engagement, and hopefully see you very soon. And if I don't see any of you from my governor cohort colleagues, I would like to wish you a very Merry Christmas and all the very best for this festive season, and hope you get an opportunity to regroup and recoup over the festive period. And it won't be right of us in the health organisation, please do not too overindulge, because that's the temptation at Christmas. So with that, wishing you all the very best for the season, and hopefully if there are things we can do differently to continue to improve the way we work with our governors, please do reach out to Joe and or Tracy, but also please do reach out to me. I'm always only too happy to understand what are we doing really well, where are things we can improve. We want to get the very most out of the work we do with you as our governor. So thank you very much and see you all soon. Bye for now.
Bye everyone.
Thank you. Bye.
Thanks. Bye-bye.